We're going to be talking about face contouring, and this is really a major area for us here in the United States, and I'll explain a little bit why. So these are some of my disclosures. I just wanted to tell you a little bit about how I got involved. I think sometimes background is interesting. And you know, when I was training in Boston, we had visiting professors come to visit us. And when I was a resident, we didn't have many residents each year. We had about 3. One of us would go pick up the visiting professor from the airport, and I was fortunate enough one time to pick up a practice in New York City called Body Sculpt, and their whole practice is basically focused on procedures under local anesthesia in office, and really treating the middle group of patients, what we call the treatment gap. So patients in their 30s, 40s, 50s. And when I was in training, I was so impressed with their work that I would fly to New York from Boston every Saturday and operate with them and see how they would see what they were doing. And we became quite close, and we wrote a number of articles together. And actually, this book just came out by Theme Publishers, which really has authorship, authors from all over the world, from Greece and Italy and South America, about emerging technologies in face and body contouring. So that's how I got involved. The other part of the reason I got interested was because it was very obvious to me that patients are demanding minimally invasive and non-invasive solutions that work. And the statistics are very clear that that's really what patients want. So, you know, even if you think about phones, you know, you can go to the cellular store. Everybody wants the latest iPhone. Nobody wants the flip phone. And I think aesthetics are the same way. Patients want their physicians to have the latest technology that's minimally invasive, that works. That's a key thing. So before we continue, I'm just going to ask, you know, who are we talking about? Because patient selection is a key feature to this whole technology. And the question really is, who are our patients? So we break it up like this. We have young patients, middle-aged patients, and older patients. We're really focusing on the middle group because the middle group has classically been very challenging. You know, the middle group, for example, your typical patient in their mid-40s, I think oftentimes we don't quite know what to do with them because doing a facelift may be overkill, and then many of the non-invasive or minimally invasive technologies don't produce enough of a result, so it's kind of underkill. So we call this group the treatment gap group. And this is an article that Drs. Theodoro and Del Vecchio and Chia wrote, really defining the treatment gap. And what it is either a younger demographic who desire soft tissue contraction without traditional scars and downtime, and they're not severe enough for a traditional excisional procedure, but they're also not mild enough for just liposuction or just a minimally invasive technology. Or we have patients who have had a facelift, for example, and then have some recurrent laxity that we want to treat, and maybe we don't want to put them through another operation. So these are the groups that we're really looking at. Now, at least in the United States, you know, this market is very large because industry knows that this is where the money's at. You know, patients who are in their 30s, 40s, 50s with an aesthetic concern are going to spend money to try to address those concerns. So cool sculpting classically has been a very popular non-invasive device. As a matter of fact, the person who invented cool sculpting trained me, Rox Anderson. He's at the Wellman Institute at Harvard. And then other types of technologies like Kybella, laser, ultrasound. The problem has been that these technologies, first of all, either don't work very well, so patients end up spending money, many times recurrently. And the other issue is many of them don't do anything for skin contraction. So a lot of them are focused on fat reduction, but skin laxity is an equivalent, if not more significant problem. Removing fat is pretty easy. I think liposuction is a great way to do that. But tightening skin is really kind of the holy grail. So we have all these technologies, and the question is kind of what's the best and what's most reliable. So radio frequency is actually not a new technology, as many of you know. Radio frequency exists in almost every field of medicine, and it's been around for almost 100 years. You know, the most classic example is Bovie electrocautery, monopolar radio frequency. We have radio frequency in cardiac ablations, oncologic ablations, pain, managing nerve pain, etc., orthopedic joint tightening. There's many applications of radio frequency, which is good because it's a very familiar technology to us. And what is radio frequency? It's very simple, actually. Radio frequency, all it is an electrical current that's traveling through tissue, and different types of tissue generate different, they have different resistance or impedance. And this is a law of physics called Ohm's law. So certain types of tissue generate more heat preferentially because of their resistance. And we take advantage of that in the aesthetic space. So there's different ways to deliver radio frequency energy, and I think this is really critical to understanding the differences between different technologies. InMode is all bipolar radio frequency. And I think there are two things about InMode technology that make me use it and make many other high-level plastic surgeons in the United States use it, is because of the bipolar nature. You know exactly that the energy is going from one electrode to the other electrode. That's one thing, and that's proprietary to InMode. So in the United States, that's the only device that's bipolar. And then the second thing, which is equally important, is temperature control. So many devices, for example, in the early 2000s, the Thermage came out, Thermi. It was a monopolar device, and the only way to control temperature was through a non-contact thermometer camera, you know, like those heat sensing cameras, which was pretty non-specific and only measured at the skin surface. The InMode technology, as I'll talk about, has very continuous temperature regulation internally and externally. And that's really a key feature, because this technology, it's like driving a Ferrari. If you drive it too slowly, or if your temperature is too low, you're not optimizing the technology. You might as well drive a Toyota. If you're going too fast and you don't have control, or your temperature is too high and you don't have control, then it's dangerous. So having very tight temperature control is critical, because we know that the difference between an efficient contraction and a burn is a couple degrees. So really getting up to that temperature without exceeding that temperature is very important to efficacy and safety. So these technologies are used head to toe. We use them all the way from the brow to the lower lid, all the way down to the calves and thighs. So our goal, and I'll talk about the devices, is to selectively heat our tissue. And this does two things. There's an immediate heating effect on the hydrogen bonds of the collagen triple helix, which causes some kind of tightening effect, which is minimal. The real effect is long-term inflammatory, basically a controlled triggering of a proliferative cascade that leads to neocollagenesis, elastin reorganization, and angiogenesis. So these are the technologies we use, and I'll talk about. This is the BodyTite device, which we'll talk about primarily at the next session, but I just wanted to introduce it. And I believe the ones in India actually have aspiration on them, which unfortunately we don't have in the United States. For us, we need to use a separate liposuction machine, but I know in the rest of the world, there's actually, the cannula itself aspirates. So this is the BodyTite, this is the FaceTite, which is a smaller applicator, and then the AccuTite is a very small applicator that's very good for under eyes, nasolabial, isolated jowls, submental areas. And this is actually, many people call, this is the Morpheus device, which many people call radio frequency microneedling. It's actually a misnomer. It's really fractional radio frequency. So what's unique about this device is that these are coated needle tips. They travel, now we have Morpheus Body in the United States, which travels up to 7-8 millimeters, but this standard Morpheus goes up to 4 millimeters, and it's bipolar, so the energy moves from the tip of the needle all the way to the faceplate of the device and traverses the whole skin envelope, which is unique. Many other devices, the energy is moving only between the tips of the needles. So we're going to talk specifically about face and neck contouring, which is one of our favorite things to do. So these are the devices we use here. This is FaceTite, AccuTite, and Morpheus. And you know, I show this to patients. I think when talking to patients, it's important to explain sort of what the aging process, what happens with the aging process, what's involved. And basically what happens is we get some laxity in the lower third of the face. So our face goes from an upside down triangle to a right side up triangle. And the primary issue is volume loss in the mid third of the face and then laxity in the jowls, submental area, and the lower third of the face. So we're really focusing on lower third. So patient selection, who are the best patients to use this on? Basically patients in their 40s and 50s with moderate laxity. It's best if they don't have active platysmal bands, because this is not a treatment for platysmal banding. So these are really the candidates that we're looking for. Fair candidates, and it really depends on the person, can be older. It's just a matter of managing their expectations. So one of the biggest benefits with these technologies is that we're able to perform them under local anesthesia in the office. We do it all the time safely and comfortably. Sometimes we just give patients some benzodiazepam or nitrous gas, which we have available. They very rarely, if ever, require any kind of significant IV sedation. And this is nice for us here in the US because we don't need a surgery center, we don't need an anesthesiologist. It really cuts out a lot of that headache and cost. So this is an example of a classic treatment gap patient. This patient's in her 40s. She's bothered by the fullness and laxity in the jowl, basically in the lower third of the face, in the jowl and submental area. So here you can see some of our markings, which we'll review more, but basically I'm marking out the border of her mandible, and then I'm going to mark out her jowl above and below that line. So I call that zone 1 and zone 2. Just to keep organized. And then we're going to mark out her, where kind of the marionette line comes down. That's where the marginal mandibular nerve becomes superficial and trifurcates, and that's an area that we want to avoid to prevent any kind of marginal mandibular neuropraxia. And then we mark out the area of laxity and adiposity in the submental area. And these are areas where we're going to do some RF-assisted liposuction. So we tumesce first, and then we perform the radiofrequency, and then we perform some liposuction where needed. These are my typical temperature settings. You know, it depends on the patient, but typically we're in the 38 Celsius external and 68 Celsius internal category. There's a number of variables that are important here, which I'll talk about, including the depth of the cannula in addition to the temperatures. So these are just some schematics on how we treat. So you can actually, and I'll show you an animation shortly, you can actually treat multiple different ways. Oftentimes we treat from kind of posterior to anterior. So an access point can be made inferior to the ear lobule, and we can treat in this direction, the lower third of the face and neck. And then we usually make one submental access point where we can treat the submental area. Some clinicians prefer to go anterior to posterior, well, where they'll access from the pre-jowl and then move posteriorly. Either way is fine. I just prefer to hide any kind of access point posteriorly. So this is a hyperlapse video showing how we treat. It's a very simple treatment. It doesn't really require too much technical skill. We're basically heating row by row, and the device has an audible alert that tells you what temperature you're at. So you don't even, you'll see oftentimes when we perform these treatments, you don't even have to be looking at the device. The beeping tells you what temperature you're at. So the key thing is just to be consistent and heat row by row as you go, and that's basically it. So here you can see we use this is a camera called the FLIR camera. It's a relatively inexpensive camera that attaches to an iPhone or Android device. It's not really necessary for the treatment, but we use it for social media to demonstrate the heat effect of this device and how the treatment is happening.
FaceTite done several weeks ago. My results pictures were done 2 weeks apart, and I was really amazed at already the dramatic difference in my neck. I was completely fat right here.
So this is my patient. This is a 2-week result. She's not even fully contracted from the radio frequency, but you can see how, you know, if you just perform liposuction on this patient, there would be concern that the skin would not necessarily kick back. And so that's an area, this is a great patient that you really say, listen, liposuction is not enough, you need something more to contract the soft tissue. Now, of course, you could probably get a better, more reliable result with a neck lift. There's some skin laxity remaining, but many patients don't want that, and they're willing to accept a 40, 50, 60% improvement without that. So this is the AccuTite device. You know, we use it all different places. This is actually Rod Roerick performing AccuTite on the brow. and we use it on the gels as well. Oftentimes we combine fractional radio frequency. This is the Morpheus device. You can see the 24 needles that come out as deep as 4 millimeters. It's bipolar as well. And the thing about Morpheus is it's very additive. We actually wrote an article talking in the Journal of Plastic and Reconstructive Surgery a few years ago, highlighting how we use Embrace. Embrace refers to Morpheus in addition to FaceTite, because the FaceTite really tightens the fibroseptal networks. Kind of, you have skin and then you have fibroseptal networks holding it in. So we tighten those fibroseptal networks almost like parachute strings. And then the Morpheus comes from above and heats the deep dermis and provides a real subdermal remodeling. We actually performed another study, also published in the Journal of Plastic and Reconstructive Surgery, looking at lymphatic drainage. You know, many of the more senior surgeons are always concerned about thermal injury to lymphatics, and actually it turns out that these devices, if anything, promote lymphangiogenesis, because it's the same progenitor vascular endothelial growth factor that's upregulated that improves angiogenesis and lymphangiogenesis, as well as neocollagenesis. So all these things work very synergistically, if anything, to improve lymphatic drainage. And we know that because of the treatment of malar edema. Many patients, many physicians now are treating malar edema with radiofrequency. So Embrace, as I mentioned, refers to FaceTite in combination with Morpheus, and we'll talk more about those two. So who is it best for? As I mentioned, it's best for the patients who are kind of gap patients, meaning middle group of patients, as well as patients who had a facelift and want some further tightening or have recurrent laxity. Or oftentimes we use it on patients who are candidates for a facelift, but don't want to have general anesthesia, don't want to have surgery, and are willing to accept a more modest result. So just to give you some technical details about the FaceTite cannula, it's kind of our workhorse cannula because it's the middle size for the bipolar or minimally invasive cannulas. It's 1.3 millimeters in cannula diameter, so you can really fit this cannula through a very small access point. Oftentimes we'll use a 16 gauge needle and just dilate it slightly. It's 10 centimeters in length. And as I mentioned, our temperatures are usually 38 Celsius externally and 68 Celsius internally. So what we're really trying to accomplish is, you see there's the skin. We have fibroseptal networks. We're really trying to heat the fibroseptal networks. And that's why we normally perform this treatment before liposuction, because we want the maximal tumescent effect to extend those fibroseptal networks and apply this energy across that collagen matrix. There is some, many people ask, is this fat, does this technology remove fat? Does it melt fat? What it really does is remodel fat. So it's not really a volume loss technique on its own unless you're aspirating, but it will remodel fat. So the beauty of this technology is the temperature control. I think when I think of InMode, I think about temperature control because there's a temperature monitor on the internal cannula as well as on the external cannula that's continuously reading. And the device will not let you exceed your preset temperatures. So the goal is basically to reach those temperatures as efficiently as possible and maintain that temperature. So the machine will not overheat your tissue. Once you reach that temperature, it's almost like a thermostat. It will not continue to fire until it just maintains that temperature. And that's really a key feature, is temperature control. So if you look at contraction, this is an example. If you look at the area between these dots and we treat a temperature, you can see there is an element of immediate contraction that takes place, and we've seen this many times under abdominoplasty flaps and facelift flaps. But really the effect primarily is a 6 to 8 week effect when you have a proliferative cascade secondary to the thermal injury. So our goal is really to treat the lower third, so basically from the tragus to the modiolus and down. And our goal is to treat effectively the jowls and the neck submental areas. This red area indicates an area that we don't want to treat. This is where the marginal mandibular nerve comes into the depressor anguli oris, and this is an area where we prefer to not deliver heat because you can end up with a marginal mandibular neuropraxia. These blue dots demonstrate where access points are possible. You can basically put an access point almost anywhere. You just want to avoid this kind of no-fly zone in red. So here's an animation just demonstrating the technology and how we use it. So as you saw in my previous video, we usually break up the jowl into zone 1 and zone 2, above and below the border of the mandible. And here you can see the facial nerve underneath and how the marginal mandibular nerve has become superficial here as it comes into the DAO. This shows you our access points that are possible. I normally only use 3. I only use 1 inferior to the ear lobule on either side and then 1 submentally. And then the blue indicates all the treatment areas and the directions that you're able to treat. Some people, like Sherelle Aston here in the United States, prefers to treat from the pre-jowl out, and I prefer to treat from the inferior ear lobule in. But it's just a matter of personal preference. Now the AccuTite, which I don't think is available there, but it's another technology that's available to us. It's just it's a much smaller version. So we're able to treat areas like the jowls and the under eye areas just through a small needle poke. So it's a nice technology for smaller areas. So basically our protocol involves the following. We mark the area with the patient either in a sitting or a standing position. As I showed you, we mark the angle of the mandible, we mark the jowl above and below that line, and then we mark submental laxity, and we avoid where the marginal mandibular nerve is superficial. It's important to identify, of course, any kind of facial nerve asymmetry ahead of time. And then we want to mark where we're going to treat, outline the jowls, outline any areas of adiposity, and if there are platysmal bands, we want to know about that ahead of time and discuss it with the patient to make sure that we are identifying it and giving them some options, possibly Botox, and there's some other solutions that we use in combination. So as far as tumescent, our mix is usually 50 cc's of 1% lidocaine with epinephrine in 1,000 liters. You know, I normally don't use more than 100 or 200 cc's of tumescent for a FaceTite in general. Other clinicians who are very experienced use double that concentration of local, so they'll use 1,000 grams per liter of lidocaine with epinephrine. Either way seems to work just fine. Now, the device measures a couple things. It measures temperature, and it also measures the number of kilojoules applied. The kilojoules are not really an endpoint, but more just a guide. So for a jawline, you may end up putting, for example, on the jowls, that area normally is about 2 kilojoules. A whole neck can be 6 kilojoules. It's not an endpoint. It's just a marker of amount of energy put in. It's a helpful data point. So normally, depth of treatment is quite important. We want to stay pre-SMAS, but we want to be at a depth of about 5 millimeters. We apply energy slowly during retraction of the device, and sometimes you need counter traction to make sure that the skin surface is flat. And we move the speed of the device at the pace that the device tells us to. So for example, when you're cold, the device beeps slowly. As you reach target temperature, it starts beeping more quickly. So that kind of helps guide you in terms of how fast you should be moving this technology. And we'll show you more about the Morpheus. So the Morpheus is unique. There are many radiofrequency microneedling devices, and I'm going to show you a video by another plastic surgeon here that really explains it well. But the key thing about the Morpheus is the energy is bipolar, so it's traversing the whole skin envelope, really providing a volumetric heat effect from the tip of the needles to the faceplate of the device. And that's really what's allowing us to heat the deep dermis and provide an additive benefit in addition to the FaceTite. So this is Dr. Sherelle Aston demonstrating a treatment. Basically, what he's done here is the same marking. So he's showing where the DAO is and where the marginal mandibular nerve is becoming more superficial. He's marking out the jowl, zone 1 and zone 2, above and below that line. And you see, this is a classic patient. This is a patient that has soft tissue laxity in the lower third of the face. So we're talking about jowls and submental laxity. And I'm just going to kind of fast forward a little bit here. So here you can see this is the platform, the interface. So he has his temperature settings here at 38 and 60 degrees Celsius. This is treatment time. This just basically means after every 120 seconds, you have to re-hit the pedal. That's an FDA safety feature. And then here are your actual temperatures. So this tells you what your actual external, internal temperature is, the time elapsed, and the amount of energy that's gone in. So what he's doing here is he's injecting tumescent in the areas that he's planning to treat. Patient's awake and comfortable. So he's tumescing those areas, and then he's creating an access point. Well, now he's doing tumescent with a spinal needle, where he's infiltrating those areas. Now, we like to tumesce quite a bit because it first of all allows for conduction of the energy, and also it allows to keep us safe from any kind of heat injury. So he's just pre-tunneling here, and then what he's going to do is he's going to treat this area from anterior to posterior. He's treating the jowl. And he engages the device, and you can see as the temperature is going up, he engages the device on retrograde contact. He actually avoids the access point here by about ½ centimeter, because otherwise you're heating the access point every time, every pass. You can see the number of kilojoules going up. You can see the temperature and the treatment time. So he's doing that whole jowl area. Now, the reason we break it up into zone 1 and zone 2 is just so that we're able to stay organized and know that we've adequately heated zone 1 and zone 2. And then once that's done and we've reached target temperature, he goes to the other treatment areas, including the submental area. Now here's a nice animation that's going to show you how the fibrosubtle networks, they kind of contract almost like a parachute, bringing the skin envelope down and contracting the skin globally. So this is not a directional contraction. This is a global contraction of the treatment area. So the Morpheus 8 I want to talk a little bit more about. So this is the deepest fractional technology available in radiofrequency. And especially in the Indian population, one major value of radiofrequency is that it's colorblind. Radiofrequency is not chromophore specific, so you can use it. We use it on African American patients, on dark-skinned patients, Fitzpatrick 4, 5, 6, because we're not worried about pigmentation changes. So this is the Morpheus device. You see how the faceplate is metal. So this is one of the return electrodes, and then the other electrode are the tips of the needles, which deliver the energy. So here's an animation just demonstrating how this technology works. Now notice here, these tips are coated. So we're not really worried about damaging the skin with heat. So we can actually deliver quite a bit of heat in the subdermal space. And the other thing about it is now we have resurfacing tips which only come out to ½ millimeter and are uncoated. So we're actually able to provide multiple depths, including resurfacing. Here's an actual treatment. So depending on the area, we can adjust the depth of the needles. So for example, on the forehead, we usually adjust down to about 1 millimeter. On different facial areas, we're at 3 or 4 millimeters. And normally we do multiple layers. So we're delivering heat in multiple layers with multiple passes. The downtime is very minimal. There's just slight redness for a day or two. So this is a great video by Subio. He's a plastic surgeon, a very prominent plastic surgeon here in Philadelphia. I'm just going to play this because he explains it very well.
About a device, but this is an exception. This is the Morpheus 8 from InMode, and it's cutting-edge, brand new technology in radiofrequency microneedling. Now, what does that mean? Here we have traditional microneedling, which is basically microscopic needles which pierce the epidermis and dermis and causes a controlled injury, which is going to stimulate collagen and improve the texture and tone of the skin. Even newer, we have radiofrequency microneedling, which is going to add energy to that needle, causing a heating, which is going to cause even more collagen formation and even more contraction and improvement. But until recently, this has been limited to these upper layers of the skin. Enter the Morpheus 8. This cutting-edge technology not only adds silicone to the needle to thereby protect the dermis itself, allows us to bypass the skin altogether and treat layers never before possible, such as the subdermal fat to cause coagulation and shrink wrapping and tightening from within. This means a non-invasive treatment with a level of power and versatility which is unprecedented. With this device, combined with modalities like FaceTite, we're going to be able to offer non-surgical solutions with a power never before seen. And it's pretty exciting, so stay tuned.
So I agree with everything Subio said. I think that we are actually using Morpheus for off-label applications, and I'm just going to share them with you. So we use it for hyperhidrosis. We're using it for cystic acne. There are articles in the dermatology literature talking about those applications. So this device for us has replaced a Miradry, is an alternative to Accutane, which patients really don't like for cystic acne. And the beauty is the actual mechanical injury to the skin surface is critical because it helps resurface and retexturize. So you really get multiple advantages from this. Here's just another video showing the actual treatment. Especially good. Now we perform this under topical anesthesia, so this is more like a medical spa type treatment on its own, and patients really like it. I mean, we have patients traveling for an hour, 2-3 hours just for this treatment. We normally do it in sessions of 3, and it can be done as a standalone, or we can add it on to a FaceTite or BodyTite technology. And it's very safe. So this is an example of an axillary. You know, many patients here in the US are very bothered by axillary rolls. So oftentimes we'll treat this with bipolar radiofrequency, minimally invasive, and then add Morpheus from the skin surface to add to that.
I don't look.
Let me give you, let me just show you this video of a patient testimonial.
I don't like the way this hangs down like this and makes me look.
Oh, excuse me.
Hangs down like this and makes me look so old, and I feel like it makes me look like I'm angry when I'm not. It just draws my face down. I love the fact that this procedure is so minimally invasive that I don't need general anesthesia. I can stay awake through the whole entire procedure. Reduce downtime, the risks, and the cost of a major surgery. Overall, the procedure was easy. It was virtually pain-free.
So, you know, patients like that who really don't want a surgical solution are thrilled to have a minimally invasive option with minimal downtime. I just want to show you a number of different results from myself and other colleagues. So these are Embrace cases, you know, real contouring of the jawline and submental areas. Now the other thing is, you know, many patients, fillers, I don't know how it is in India, but in the United States, fillers have become like a pandemic. Everybody is using fillers to try to contour and lift, etc. It doesn't really work, and we're seeing more and more patients with overfilled faces. And I think the problem is they're trying to treat soft tissue laxity with volume, but really it's almost like putting in larger breast implants for a ptotic breast. You need to address the skin laxity. That's the problem. And I think when we try to do that with volume, it just requires too much volume. It doesn't look right. So we really need a solution to address soft tissue laxity. It's a very popular technology in men because many men are bothered by the submental area. And just a number of other examples just to show you types of results that can be obtained using this technology. So for us, you know, as a young plastic surgeon, this has been a game changer because I can perform these procedures in office efficiently with rather low overhead. You know, basically my overhead here is tumescent, a handpiece, which is not very expensive, and time. This is one of my cases. So I like to show a lot of before and afters. I always get nervous when I'm at a conference and somebody's introducing a technology and they only show you 1 or 2 before and afters. It's not even theirs. It makes me a little cautious. But here in the United States, this has been a game changer for many practices. And you know, many very senior, prominent plastic surgeons who typically don't adopt technology have really embraced Embrace and radiofrequency. And we use this all over the body. So thank you very much for your attention. I'm happy to discuss, take any questions, and this is the conclusion of my presentation.
Thank you very much, Dr. Dayan. I'd like to call our two panelists, Dr. Gupta and Dr. Bave. Can we see you, Dr. Bave? I think she had asked a question for Dr. Dayan. I'd love to see you, Dr. Bave.
She might be around. She'll come back. Yeah.
Okay. She did ask a question, so let me ask you her question, which she had asked in the chat. How do you, I think you answered, but I'd like you to clarify. There you are. Would you like to ask? Would you like to ask your question, Dr. Bave?
No, you can go ahead. I have already fired the questions, so you can just read them out if you don't mind.
Okay, so the question was, how do you avoid nerves while treating face, especially while using sublobular access point? And how often do you get hyperpigmentation? How should it be treated? And is it more common in darker skin types?
Great question. So as far as facial nerves, that's probably the one area that we're most cautious about. And as you know, the real facial nerves that are actually a problem are the border ones. So frontal branch, for example, and then marginal mandibular. Because the buccal branch and zygomatic branch, there's enough crossover that it's not clinically problematic for us. Using tumescent is critical to hydrodissect the smash down and the area that we want to treat up. So I actually like to use a lot of tumescent for that reason. The tumescent allows us to do a number of things. It allows us to extend the fibroseptal networks that we want to treat. It allows the radiofrequency to conduct more efficiently. And by the way, we also use a water-soluble gel on the skin surface to allow conduction and also cool the skin surface. And then it also protects nerves because it functions as a heat sink. So I'm only treating, the nice thing about bipolar radiofrequency is I'm only treating between the external and internal electrode. It's not a monopolar. The problem that I have with monopolar technology is there's no real control. It travels through the path of least resistance to reach a grounding pad remotely. So you're not really getting a volumetric heating. And I'm even happy to show you some preliminary data that we're about to publish comparing bipolar radiofrequency to a popular monopolar device here in the US. And basically there's no heat signature with monopolar devices because the energy is just moving through the path of least resistance. Now, marginal mandibular nerve neuropraxias can happen. They can happen with just liposuction, just from traction. The good news is that they happen and they go away. You know, I've never seen a transection or a permanent problem. The other good news is if it does happen, you just Botox the other side and everything evens out until it resolves. The bad news is it can happen, and normally for me, it only happens on celebrities or influential people. I never have it happen to Joe Schmo down the street. So I have a patient who's a very famous sculptor. He's public about it. His name is Richard McDonald. He's done Cirque du Soleil and all these other things. And I told him, I said, Richard, there's some risks to this treatment. And one of them can be a marginal mandibular neuropraxia, and it only happens to people who are important. So let's see how important you are. And he did have a little bit of a weakness for a week or two, and it resolved. But, you know, to me, that's a relative, you know, everything we do has a risk benefit. And, you know, it just has to make sense. The risk has to, anything, you know, like even cool sculpting, for example, which many people consider to be quite safe, you know, paradoxical adipose hyperplasia, nerve issues. The more effective something is, the more, generally, the more risk is involved. But I think that with radiofrequency, the risk profile is very favorable. And I think if you tumescent enough, it's a very rare occurrence, maybe 1 to 2% of the time at most.
Thank you.
Dr. Gupta, I see you wrote a comment. Maybe you'd like to just ask Dr. Erez directly.
Yeah. Great talk, Dr. Dayan.
Thank you.
Enjoyed every bit of it. So, do you think that the results of skin tightening effect is equal if you're talking about Caucasian skin or an Indian skin? Do you think there is a difference? And if needed, do you think you will repeat the neck tight or face tight session? And if you repeat, after how much gap?
It's a great question, actually. Very interesting question. So what I've noticed, and I don't have a necessarily good explanation for it, but what I've noticed is that patients with darker skin tend to do better. And the reason for that, I think, is because they have a thicker dermis, more fibrous soft tissue. I'm not really sure, but I'll tell you, anytime I see a dark skinned patient who wants FaceTite or BodyTite, I'm all over it, because they don't have a better, like, those are not patients that can have laser treatments, or a lot of things are off the table for that group. Like, I'm sure CO2 and erbium lasers are not very popular in India, you know, because of pigmentation issues. But radio frequency, I've done this on many African American patients. They have fantastic results.
Dr. Bave, would you like me to ask the next question? Okay. So
no, I will. Yeah, you can go ahead.
So we have another question from Dr. Bave, and thank you for that response. Do you combine Vaser and neck tight? How do you change your parameters?
Sure, great question. You know, let me just answer Dr. Gupta. I just remembered he asked another part of that question. So as far as retreatment, I normally don't feel that I need to retreat. And the reality is, I think that if I treat a second time, it's generally less effective than the first time. I think if I do a thorough treatment the first time, that's my best shot. Now, if there's a small area that I feel like I can get a little more and it's not a big deal, then I'll do it. But, you know, even if you look at a lot of the data from other technologies like cryolipolysis, etc., the secondary treatments are always less effective than the first, because that was kind of, so I don't think it's additive. I think it's probably less effective as you go. But, you know, Morpheus, for example, I have patients that come for Morpheus annually. And I even tell them I think it's overkill, but they like it, so they come annually. And they see an improvement, and I see an improvement. So I think there is an improvement. It's just a question of how much. I think your most dramatic improvement and the best shot to get a phenomenal result is your first shot, RF-assisted lipo, where you're piggybacking, you know, because lipo alone is going to give you some soft tissue contraction. So this, to me, this is like it's like supercharging that. So you can really, like that patient I showed you with a really heavy neck, your best shot is the first time for sure. And then as far as pigmentation was also asked about, I've never seen hyperpigmentation from this technology. And I think, you know, with Morpheus or FaceTite, personally, I haven't seen it. Now, as far as using ultrasound assistance in a combination with radio frequency, it's a great question. I actually use ultrasound in the body when I do lipo all the time. I don't think ultrasound does not get nearly as hot as these temperatures do. But I like ultrasound lipo. I think it's helpful. I think it minimizes blood loss. I think it's good in fibrous areas. And I think it's totally safe to use with radio frequency. So I use a Vaser equivalent with RF all the time in body areas. I don't really feel the need to do it in the face, to be honest with you, just because it's less lipo, and I feel that the RF is more than sufficient for the soft tissue contraction.
Okay, are there any more questions?
Yeah, I have to ask one more question. It was a really good presentation, and I think it has thrown a lot of light on how we are going to employ it in our practice now. What I would like to ask you is, supposing a 40-year-old patient comes to you, what is the time frame you would give her for the lasting results? You know, when would you like to do it again? She says that I want to maintain my appearance with you till I am 80. So how will you, you know, give a projection of?
Yes, it's a great question. So everybody asks that. People want to know. So the number of questions are this: Show me the before and after, which is great that we have so many of them that are consistent. B, how much is it going to cost me? Those are the two key questions. And then 3, how long is it going to last? What kind of maintenance is involved? So the results we have, and I didn't show it because I didn't want it to feel too commercial, but InMode has many, many celebrity, at least in the US, and I'm sure the celebrities are known internationally, celebrities who use radio frequency because they like it. So, people like Paula Abdul, the Kardashians, and, it doesn't mean much to me, but to the population, if it's good enough for Kim Kardashian, then it's good enough for Mary Smith, basically.
Sure.
So that's important because patients, this is not some off-the-shelf technology that nobody's tried. I mean, major celebrities in Beverly Hills and Miami are seeking these treatments. And we have those people here too, who are not on TV that are coming in for it. Now, as far as people will ask you, how long is it going to last? So I just tell people brutally, the beauty of it is so many people want this technology, you don't need to sell it. You don't need to, because they're going to do it. And so you could just be brutally honest. You tell them, listen, nothing lasts forever. Nothing, not even diamonds. And so what's going to happen is you're going to have this treatment, even a facelift. When people ask you, how long is a facelift going to last? I don't know. You're going to get a facelift, and then the aging process continues. Gravity doesn't stop, unfortunately. This is where we are. So what happens is I'll show them a biopsy specimen. We have actually, and the InMode has a wonderful resource center that has a lot of these assets. So there's biopsies that we've taken after radiofrequency, and you can see the collagen layer thicken after treatment, and you see reorganization of collagen. And basically I explain to them, this is like a shrink wrap. This is like, imagine taking your skin, applying an energy, and applying a controlled thermal injury that's going to thicken your collagen, and it's going to turn back aging. How much is not easy to predict, but here are the before and after results, and you can judge it for yourself. And then the aging process continues, and that wouldn't, so normally I don't have to retreat a patient for 3 or 4 years at least. You know what I mean? That's kind of my ballpark. But even a facelift, even a facelift that would cost someone 3 times more and have downtime and have general anesthesia, etc., even that's not going to last you more than 5, 6, 7 years in reality. So, but I think, what happens with patients are, there is no better option, minimally invasive, that I'm aware of, honestly. We have nurses here doing threads and fillers. I don't care how many threads you use and all that kind of stuff. Ultimately, they end up here and they end up doing this treatment. It's unfortunate because many times patients are kind of worn out by the time they get to me. They've already spent so much money trying filler and threads. They're already so far in. They just want something that works. But at least in the US, many people are moving away from fillers because fillers have had a fair number of complications. Chronic swelling, lymphatic issues, malar edema, Tyndall effect. So, and fillers, how long does a filler last? 6 months, maybe, if you like the treatment. So for us, this fits a really nice gap for us. And, I can do 4 or 5 of these in a day, and I don't need to see an anesthesia. I don't know how you guys operate there, but here in the US, having surgery, working at surgery centers is a major hassle. And honestly, they don't want plastic surgeons because they make much more money doing insurance-based cases. They don't make as much money doing cash pay cases, so they don't even want us. So it's very beneficial for me to be able to do this in office under local.
It's actually the reverse in India.
Really? Well, then you're lucky.
So it does not add too much to a cost if we take our patient from office to operation theater. But yes, yeah.
For us, the overhead on this is like 5%. It's very low.
What is the maximum number of times you can repeat this radio frequency on a face? That is what I meant when I asked you about the 40-year-old lady. So would you have to go for later for some other modality? And before that, how many times would you repeat this for her?
The max I've done it personally has been 3 times.
Okay.
I don't think there's a downside to doing it over time, more times. But as they age, they may be what we've been doing more for patients who are older and not great candidates for RF. but don't want a facelift is we'll do RF and combine it with a mini lift under local. And that's been a nice treatment. Or there are some treatments for the neck area that we've combined. There's a technology here in the US called Elevate, which is basically, it's a very simple thing. It's basically a suspension suture that goes from mastoid to mastoid and just helps kind of get the neck up. So in combination, for patients who are kind of on the older end, we can combine technologies.
Are there any more questions, Dr. Gupta or Dr. Bave? If not, then I think we'll close today's webinar.
Just one last one, if you can allow. Yeah.
Okay,
So
yes.
when you treat the eyelid with AccuTite, what are the layers you are aiming to treat?
Sure, that's a great question. So for AccuTite, so actually we went through this and we did studies on cadavers, and we really went through this very deeply with oculoplastic surgeons like Sean Paul in Austin, Texas, and Kami Parsa in Beverly Hills. But basically, AccuTite on the lower lid is a very effective treatment. We just form a wheel of local at the lateral orbital rim, and then we take a little bit of local or tumescent, just a few cc's, right inferior to the orbital rim, and we hydro kind of infiltrate the suborbicularis fat pad, the SUF.
Okay.
And then we just take a 16 gauge or 18 gauge needle, just make a little poke here. The cannula fits right in there, and it's literally 2 or 3 passes in the SUF layer inferior to the orbital rim. It's very safe, and it just helps bring that area down a little bit. And sometimes you can combine it with a little bit of nano fat transfer inferiorly, so it's kind of a plus-minus effect.
Oh.
It's much better and much safer than fillers in that area, in my opinion.
Yes.
Well then, thank you so much, Dr. Dayan, Dr. Gupta, and Dr. Bave for being with us today. Thank you everyone for attending. We've recorded the lecture, and so it will be available after for viewing. And I invite you all to next week to hear Dr. Dayan speak to us about the body. Thank you, and have a good evening, everyone.
Thank you all very much. Thank you for your attention.
Yeah,
so
thank
much.
you, and looking forward for
Have
next
a
week.
good day.
Thank you, you
Sure.
too. Thank you very much. Thank you.
Bye now.